We have a panel discussion now, and this is a great opportunity for you to meet some of the experts that we have at Roswell to address some issues. Obviously, we're going to have them give a brief introduction to their areas and the concerns and the issues that they identify around cancer treatment and around cancer survivorship. We obviously have Gina on the panel. And when I say your name, if you could identify who you are. We have Dr. Tessa Flores, who's my partner in survivorship. She's the medical director of screening and survivorship. She addresses all the things that happen in the clinic and has really set up very nice protocols so that we do a comprehensive approach to our cancer survivors. We have Amy Gallagher, who is a clinical psychologist and is in charge of the Employee Resiliency Program. And she is available to talk about some of the psychological challenges or questions that you might have. We have Elizabeth Repasky, who is the vice chair of immunology. And as Betsy will tell you, she is, very attuned to how the immunologic system addresses cancer, but also stress. I'll just note that Dr. Repasky has some hearing issues, and so the person sitting next to her is going to help to interpret the questions so that she can hear you. We have Cassandra Jackson, who is our senior health referral person who has rebuilt the wellness program at Roswell and brought it back to life now in person. And we're very, very grateful to have her energy here. And Mark Farrugia, who is a physician in radiation medicine. And when he introduces himself, you'll understand why we brought him in. He's really attuned to what happens with radiation and the long-term effects. So I've asked each of the panel members, starting with Cassandra Jackson, to give a brief introduction about themselves and sort of the area that they have. I have the cards that you've turned in. I've given them to the appropriate person on the panel. We'll go through the cards first, and then we want to open it up, like we did just a few minutes ago, and have you ask questions, because I think, for every question one of you asks, there are 10 people who understand what that question is about. So we'll just start with Cassandra to give an introduction.
Good morning. It's so good to see everyone. My name is Cassandra Jackson. I am the wellness coordinator here at Roswell. Our wellness programs are designed for you and to you to improve the quality of life for those who are going through cancer. This morning, we had a table out in the Gaylord Carrier room, and we had all of the different programs that you can participate in. We have also rebuilt back our support groups. We have about 13 support groups up and running. If you don't see yours out there today, you can contact me, and we can look to getting that getting it back up and going. You can also find out what's going on during the week. I know a lot of times when some of you guys come here, it looks like it's going to be a long day here. And some of us sit in waiting rooms and we don't have things to do. So if you're looking to do some things, we have something throughout the week. All you would have to do is go to our wellness page and look at our calendar, and there's something for you to do every day. So don't be stressed out about what's going on. Find something to do to take your mind off of it, and you might meet a friend. Thank you.
Hi, good morning. I'm Dr. Tessa Flores. I am the survivorship and screening doctor. I have a team of APPs that actually see cancer survivors and patients who are at higher risk for cancer. So who is a cancer survivor? Everyone here. There is a definition, and it may not it may not be true for everyone, but it's a cancer survivor is someone at the day of diagnosis. And we take care of all those patients. We have patients who we follow them. They've graduated from their primary clinic, and then we surveil them for other cancers and also screen them for second cancers and also help with symptom management and also possible long-term complications of the treatment. But we also do one-time consults of patients who are in active treatment to help you get into support services, such as Cassandra. You all due to a quality of life. So we address your fatigue, your physical issues. And probably the biggest thing is also a care plan, which is what we consider like a roadmap. The majority of you probably know what a cliff note is. So it's sort of like a abridged version of your cancer history. So everyone aware it knows how to surveil your cancer, the possible complications of your treatment. Oh, I don't want to spit though. I have a little list. And also, you all know what could come from long-term treatments, and it's a communication between us, the oncology world, to your primary care doctors. And I think that's one of the biggest things that we're trying to figure out is how to communicate with you and the community providers. So you can either be transferred to us so we can see you and do a whole person, or a one-time consult to hook you up with things.
Hi, good morning, everyone. I'm Dr. Amy Gallagher, clinical psychologist, and my role here at Roswell is to provide support and programming to our staff in order to build up their own resiliency and to prevent burnout. I lead a team, a very small team, but a mighty team of 3 other folks who are working with me, a coordinator, as well as our 2 employee assistance program coordinators, in order to take care of the folks who help take care of you.
Hello. Hi, my name is Mark Farrugia. I am a radiation oncologist. I primarily treat head and neck cancer, lung cancer, and lymphoma. However, I've treated most cancers head to toe with radiation therapy in my career. So my role here is to help either treat or manage cancer as radiotherapy. And what that means in terms of how we do that varies broadly across treatments. So when I meet with patients, generally my role is to explain how we start with that process from either a simulation CAT scan, which you go through most patients, the planning phase, what to expect on treatment, and what to expect in the follow-up period. And so what your patient experience are very widely based on disease sites. So it's generally very much a tailored discussion, but I'm more than happy to answer any questions regarding that.
Hi, everyone. I'm Betsy Repasky, and I've been at Roswell Park, well, I don't want to say how many years, but it's closer to 35 than it is to 30. I am very excited at this later time in my career by my research. It took a long time before I started to feel that we're making now some discoveries that I wish I had made 30 years ago, but I'm so happy that they're happening now. And that is on the relationship between stress and the immune system. I work with mice. I'm a laboratory scientist. I work with students at the lab bench, and our own research is convincing us that getting rid of anxiety, getting rid of chronic stress is an extremely important part of chapter 2. Of course, we all want to get rid of stress at all phases of our life, but our research is telling us that a cancer diagnosis increases the kind of stress exactly at a time when you don't want that to happen, because chronic stress, based on our work, reduces your survival and your response to therapy for many people, not all. And so with this knowledge, we've become extremely excited about learning strategies that we can use to reduce stress during cancer therapy, and not only for patients, but also for caregivers. And this all relates to our immune system and our ability to fight not only cancer, but things like COVID or the flu. All depend upon your ability to reduce as much as possible the effects of anxiety, fear, and depression. But especially we're interested in those patients who receive a new cancer diagnosis, because we know that that's a very difficult experience for everyone.
Okay, thank you. So I just on that line, I wondered if we could have Amy and Tessa talk about the stress related to having scans and to coming into Roswell. Amy, I gave you the question. Do you want to talk a little bit about that?
Sure, absolutely. When you are coming in for an appointment, especially for a scan, there can be such a overwhelmingly sense of uncertainty. What's going to happen? What's the outcome of the procedure going to be? So, especially when you're in the waiting room and as you're going in for your scan, there's a quick little grounding technique that I really would like to share with everyone. This just helps to get you to think about your sensory input that's coming in, and allows you to stop thinking about what's going to potentially happen in the future. So this technique is called 5-4-3-2-1 grounding, and the first part is to see or to look at 5 different things and name them in your brain of what you can see around you. The second is 4 things that you can touch, so tactile. The third is 3 things you can hear, 2 things that you can smell, and 1 thing that you can taste. And that just allows you to tune into your sensory input, to stop kind of that train of thought or those negative thoughts that you may be thinking about, the future of what could happen or the what ifs and that potentially could happen. I do sometimes have people ask me, well, what if I don't remember if it's 5 things I should see or 5 things I should hear? It's okay. Just really tune into those sensory things. And as you are able to focus on your senses, it may help just calm your body down in the moment before your scan. And you can do it a couple times as well.
Tessa?
That is it.
Don't touch it.
It's working. That's great advice. It's called anxiety. It's very common. Happens to the cancer survivor, the caretakers. We go through it with you also. It gets better. Sometimes it goes away. Just realize, that, and accept it and be graceful, right? Just give yourself some grace, knowing that, in a month, I'm going to go to Roswell. I'm going to have to get a CT scan. I don't know what it's going to show. Bring a support person with you so they can be there with you. As a clinician, we all understand that the scans or seeing us is a anxiety-provoking thing. And then also, it should get, once you leave the place and get the results, it should be better. And hopefully, as time goes on, the periods of getting anxious and the periods of getting back to normal after the results will be shorter and shorter. I have patients who are 20, 30 years out, and they're like, yeah, it's just another day. And sometimes maybe all of you will get there, unlikely, but just give yourself some grace, and everyone goes through it. And the clinicians know that you're thinking, what if it comes back?
Tessa, could you answer some of the other questions?
Yeah, so that kind of leads into how to deal with what if it comes back. It wears on you. It does. It wears on you. I'm going to do the answers from the clinician standpoint point of view, and then Amy will do the psychological, which I think is the big thing. So cancer can come back. Another cancer can happen. It's difficult from the clinician standpoint when we give you the diagnosis that the cancer has come back. On our end, we have to, we see something on a scan, it looks suspicious, we tell you, flood of emotions, memories come back. We need to figure out, is this your old cancer, a new cancer? So we will need something called a tissue diagnosis. It's going to take us a little bit of time to arrange for that biopsy. So as much as we want to tell you what it is, we need a little bit of time to figure out what it is so we can get you to the right oncologist. You know, you can be seeing breast medicine. Let's say you haven't graduated to survivorship and you're going to breast medicine and they see a spot on your breast. That's usually, we can say that's breast. You're a colon cancer survivor. You're within your first 5 years. So you're getting your annual CT of the chest, abdomen, pelvis. And we see a spot in your lung. We cannot assume that it is colon cancer. We're going to need a piece of tissue to say, is this colon or is it lung? So we need a little bit of time so we can figure out who to send you to. Do you go back to the colon guys, or do you now need to see thoracic medicine? So as much as you would like to know, like, what is my treatment now? We need a little bit of time. We, the clinicians, need a little bit of time. So that way we don't say, oh, I think it's this, and then later on it's actually this. What can you do during this waiting time? Because it is so stressful and it brings back memories, is find your support. Lean on those people. Break down. It's okay. You know, this is the worst news you could get, and we understand that. But you've already beat cancer once. It doesn't mean you're not going to beat it again. And then there's Cassandra to help you with the support services, but I'll let Amy talk about how to, like, you know, get yourself there mentally or start.
So first, I just want to say that it's okay to grieve. It's okay to be angry and to feel sad and to feel frustrated and uncertain. All of those feelings are absolutely okay to have and to feel and to express. So feel the feelings first. Then just to jump on to what Tessa just said, that grab your support system. Find your support system, whoever that is. Could be somebody at home, a family member, caregiver, someone you met in a support group previously, friend down the street, neighbor. Find those supports and lean on your supports. And then in those times where maybe you might need a little bit distraction, your thoughts are running amok, think about a memory that you can savor. And when we're thinking about savoring a memory, we really want to see or, remember what happened, the visuals that we saw, the smells that we smelled, what we heard people say, or, if it was around food, the taste of the food. Really put yourself back in that time and think about it, and then also feel those positive feelings that are associated with that memory as well. And if you're having trouble coming up with a memory, grab your phone. You've got a million memories in that phone, and a lot of them are really positive.
So Gina, you got a lot of questions. Can you kind of summarize some of them and try and answer the ones people asked you?
Can you clarify the 5 people? Can you hear? Is this working?
Don't mess with your.
There we go. Okay. Can you clarify the 5 people exercise? This is actually really interesting. So write down those people. Jim Rohn, the motivational speaker, said you are the average of the 5 people you spend the most time with. So think about that, right? Who are those 5 people outside of people that you spend time with because they live in your house with your family and your friends? Because that circle are individuals you have chosen. So write them down and then do an assessment. What do these people bring you joy? Are there toxic people in this group? Are there people who are compassionate and helpful? Because Nicholas Christakis was whom I worked with at Harvard, and now he's at Yale. He did a study, he's done a number of studies on friendships and how friends affect everything in your life. Your mindset, your weight, whether you vote. Your friends are critically important. And if those friends are not serving you, particularly when you are dealing with an illness, then jettison them, or have your chief of staff jettison them, even if it's temporarily, because you deserve to be with people who bring you joy and who are inspirational. Think about conversations you have. When you are with your friends, they affect the conversations. If you're with someone who is really always a victim, you're going to hear about their victimhood. If you're with people who are just downers, that's going to direct the conversation, and those are the thoughts that are in your head. So by surrounding yourself with 5 people, take your inventory and see if you need to, boost it in some way with some more positivity. And really don't spend time with people who drain you, especially at a time when you're dealing with your own health and wellness.
Okay, so you have another question.
Can you ever go back to being the person self you were before, or has the cancer forever taken a part of you away? It feels like I have lost myself. That's a really powerful question, and there might be other people on the stage who can answer it. What I would say, though, is do you really want to go back to the person you were? Or has there been post-traumatic growth? And that's when I suggested earlier, you just keep a list on your refrigerator somewhere of what you've learned in those experiences and assess that periodically about how you have broadened your knowledge. And think about when you were a teenager, would you really want to go back to that stage? Life has, polished the edges. It's helped you grow. So when you think about it from that perspective, that might be a valuable way to proceed.
Does someone else want to weigh in?
There's a reason why this is called Chapter 2. We do crave our life prior to cancer, but the return to that is usually not attained. So we embrace the changes that the cancer journey has provided us, and it will be what we call a new normal, and hence Chapter 2.
So Mark, could you talk a little bit about, there are a lot of people in the room who are either going to get or have had radiation. Could you just talk a little bit about, what happens with radiation, maybe even some of the long-term side effects that you see in patients from a variety of cancers?
Does this start? Yeah. So radiation therapy in general is using ionizing radiation to treat cancer. Globally or nationally, this can be done with either photons or X-rays, which we use here. Other centers also use particle therapy. But the general gist is you're using these means to damage cancer, namely the DNA, such that when the cancer tries to divide, it dies. Radiation therapy is a local therapy in the sense that the side effects of radiation therapy are largely confined to the area we're treating, such that some treatments, the side effects are in the short term and the long term can be quite minimal, to be honest. If we're treating a small area, depending on the tissue, the on-treatment side effects, either during treatment or shortly thereafter, can be quite manageable and very, very minimal. And consequently, the long-term side effects can be similarly much easier. In the same vein, more delicate areas of the body, the side effects during treatment can be very challenging. and the long-term side effects can be oftentimes difficult to manage. So one of the harder sites to treat are head and neck cancer, and this has to do with two reasons. One, it's precious real estate, no matter how you slice it. We use our head, neck, our throat for a number of vital functions, and this is eating, drinking, talking, breathing. When you're treating head and neck cancer, there's no way around not treating those areas, because those are the areas the tumor may be in, and there's also at-risk areas, in either a single neck or in both necks that we invariably have to treat. The side effects from that can be, namely, difficulty with swallowing, dry mouth, altered taste, and a certain skin reaction as well. Long term, this could be, continued dry mouth, over a number of years, problems with swallowing, and the skin can actually scar down as well. So we have a number of ways to try to manage the symptoms that are on treatment, both with either pharmaceuticals or rinses or things we can do to help kind of get you as optimized as possible to manage, and to actually avoid any breaks during treatment, to avoid any increased weight loss, and to avoid other things like feeding tube, which we don't do very often anymore. Furthermore, we have other different strategies to help kind of mitigate some of those long-term side effects as well. And how we approach that really is going to be a function of kind of where we're treating, and our expectations are really what the long-term toxicities are going to be.
So just as a question, can some of your radiation treatment increase your risk of getting a second cancer?
True. So what we call a secondary malignancy or radiation-induced malignancy is a real phenomenon, but it's also incredibly challenging to quantitate. Radiation-induced cancers are usually a function of time, several decades. And so if I'm being honest, most patients in their 50s and 60s, it's something you really don't see very often. Say we're treating breast cancer, there are kind of radiation-induced sarcomas, but their frequency are extraordinarily rare. And so a lot of patients will have anxiety over that, but ultimately, when I discuss with patients, it's kind of being, if they're overly concerned about it, it's kind of a penny wise, pound foolish. You're worried about something that has a 0.0001% incidence versus your current cancer. So it's something to discuss, something to be knowledgeable about, but oftentimes it's quite rare. Where secondary cancers tend to have more concern is the very young population, so pediatrics or the young adults. And then it's more of a nuanced discussion and more of a real concern. And so for those patients, we also have advanced screening or earlier interventions to potentially detect that earlier if there were to be the case.
Thank you. Betsy, I wondered if you got a question about why cancer is so hard. Why are we still trying to cure cancer? And you have such a broad view. We wonder if you could tackle that one.
Sure.
No, don't.
This is actually a question that my own family asks me all the time. You've been doing cancer research your whole life, Betsy. What do you see has improved throughout your career? And the fact is that we have made a huge amount of progress. We don't often hear about all of the patients who do not die from breast cancer following their diagnosis. We don't often hear about the patients who go on to live fulfilling lives after a cancer diagnosis, because we think mostly about those individuals all around us whose lives have been terribly impaired by cancer. But I'm actually extremely encouraged by some of the new developments in immunology. And if I could just take 1 minute to talk about the reason it's difficult to always get rid of a cancer is because cancer is one of our own cells. And the immune response that we have is geared toward bacteria, toward viruses, and we do not want our immune system to attack our own cells. When that happens, it can be a terrible autoimmune disease. So think about what we're asking with cancer treatment. We're asking to identify a tumor cell in the colon, for example, or in the breast, that's right next door to a normal breast cell or a normal colon cell or a normal brain cell. So we're asking our bodies to respond to therapy in a very precise way. But remarkably, that is exactly what is happening. It's also not appreciated that all of us in this room who may be free of cancer at this moment, we're not always free of cancer. All of us have small malignancies that develop throughout our life and are eliminated by the immune response. It does work. And what we need to focus on is when that balance starts to shift, when the tumor escapes our ability to control it. But cancer processes are a part of normal living cells, and it's part of aging, but it's also part of being a very young person as well. Malignancy is so biologically entwined with normal cell life. It's very difficult to separate how to attack those cells. But in fact, we're making huge amount of progress in the field that I care most about, which is immunity. We've learned how to stimulate that tired or exhausted immune response against cancer by the use of checkpoint inhibitors and a variety of other therapies. And even my own family says, well, if you cure cancer, will you be out of a job? And I would love that, but actually there are so many different parts of the cancer problem. There is so much to work on that's going to take me the rest of my career, but I'm so happy with the progress that we are making. We certainly haven't eliminated stroke as a cause of death or heart disease. Again, we've made huge amounts of progress in improving the lives of individuals with cancer, and I'm very proud of the effort here at Roswell Park.
Thank you so much. Okay, so we have about 10 minutes. And we have people with microphones. We also have a few questions that are unanswered. So if someone wants to ask a specific person, we'll try and address that. And if there's a gap, we have some other questions.
I'll go ahead and answer this question while we're trying to find volunteers. I have a question. Is there research validating the use of low-dose vaginal estradiol a couple of times a week while taking letrozole? This is obviously a breast cancer patient. There's a lot of us here. I'm not sure about research. There is consensus guidelines that can say, yes, you can use a vaginal estrogen to help with the side effects of aromatase inhibitor, such as letrozole. There is hesitancy in the cancer, the treatment, the oncologist, because of your ER/PR status, the concerns of can this make your cancer come back or recur. So we recommend the lowest dose that you can go and the least amount. So you usually start off with 2 times a week, but if you can get it down lower to control your symptoms, the answer is yes, you can, and ask your medical oncologist.
Thank you. Okay, we have some questions.
We have a question for from the audience here, and that is, if and when death occurs, can one choose to donate their body to research at Roswell Park?
So the answer is yes. And we have a program here that is called, it's an autopsy program where you can donate through an agency in Buffalo, where they will both look at where you had the cancer, and researchers can get those samples, which is really important. But we can also look at other organs that you have that are not affected by cancer, and basic research looking at markers and stuff like that. So they do have that. Your oncologist should know about it. If not, you should send us a note. I think we'll keep that question. But we do have a program where you can donate your body.
Oh.
Do we want to get him out? Oh, you've got one. Okay.
Good morning. I just have a few bullets I want to share. Would you like to hear something really positive?
Yeah.
Exactly on this day, 6 years ago, I had my surgery and a lung removed at Roswell. And I'm clean.
Yeah.
My wife has been my support group, and my black lab. Those are the two people that supported me. My lab wouldn't let me out of the bathroom when I was going through chemo. She'd follow me around. Number two, I want to thank the Roswell for doing a research study with the VA regarding the effects of Agent Orange. I served 2 years in Vietnam. I flew through the spraying, and I walked through the spraying thinking that it was a good thing for veterans, but we know differently now. Dioxin that was sprayed there had 13 different isomers, and I say this because I used to consult with the New York State Dioxin Commission, and I handled the paralegal work for the veterans in Buffalo to get on the class action lawsuit. A $90 million business for the chemical companies. So any veterans here that haven't been screened by the VA and don't know about the recent PACT Act regarding the burning and the chemicals that were being burnt in Iraq and Afghanistan need to get checked. And I'm so glad to see the involvement with the VA. Now, my last thing is that things have probably changed regarding your intake counseling that you do for survivors. But after my cancer, nobody explained to me, well, they said you got 3 choices with chemo. And this is the worst one, but it's the one that really works. And boy, was it the worst one.
Yeah.
I've never suffered. I would go through 4 more tours in Vietnam to go through that. But God brought me through. Roswell brought me through. And I'm so appreciative of that. And I just wanted to say that in the final looking at this, I think it would have been important for the staff, my team, to explain a little bit more of the consequences that could happen with chemo. Nobody told me that diabetes, neuropathy, stage 3 kidney disease. So my battle's not over, even though the cancer's gone. My battle's not over, and I keep everybody here in my prayers. Thank you.
So I have a question for the scientists. So you're saying that every human that's born has the potential of getting cancer cells. That's to the scientists, the researcher.
I'm so happy you asked that question. That's what I was It's on. Too many things in my hand. I'm so happy with that question because it gets to the basic biology of cancer that many of us work on here at Roswell Park. A malignant cell is so similar to a normal cell. A cell wants to divide. If I broke my leg falling off the stage later today, I would want every cell in my bone to start dividing very quickly. That's part of the normal wound healing process. But I don't want my immune system to attack my leg as it's starting to divide. So just simply dividing can be a stimulus to the immune system if it's a cancer. And all of us, our research tells us that everyone in this room has had a tumor or has a tumor that is undetected, but it is controlled by a balance of factors that greatly involve the immune response, but it's a very, very sensitive balance. Do I attack the bone cells that are dividing because she broke her leg, or does she have a sarcoma in her bone that's an abnormal malignancy causing those bone cells to divide? And this is, for me, the most interesting set of research that is going on here at Roswell Park, is that we're learning how it is that some people can control that tumor and never have it become clinically detectable, whereas in many other cases, those tumors start to grow and are not controlled by the immune system. I have a tendency to go on and on and on about our own research, but I'm very excited about the knowledge base that we have now about what makes a cancer grow out of control and why it's controlled. But I'm sure you all know the anecdote about prostate cancer. For men, even in their 30s and 40s, many individuals already have an indolent, small growing tumor that doesn't that doesn't grow off. And so we need to learn why that's controlled in some individuals. See, I go,
We're kind of running out of time. We had a couple questions. We want you to write your question on a piece of paper, and we will send the answers to you as a group. But Gina, do you want to close us out and this last comment?
Wait, let's turn off. No, there we go. Okay. I just want to share, someone wrote, Eckhart Tolle was very helpful to understanding others' hurtful behavior. More accepting of self and others helps with meditation also. And when I will send a book list of what I recommended, and I'll add a couple to Laurel to share with you. And if I can find something from Eckhart Tolle on this, it's a specific article or resource, I will share that. And then the last question was, how do I stop pushing the people closest to me away during my grief and treatment? They want to help, they keep showing up, then I feel bad for feeling bad. It's a vicious cycle. Is it normal? My advice would be, this is your moment to indulge yourself in any way possible. And perhaps just saying, I appreciate your love for me and your being there, but I just feel I need to be alone right now. And I will let you know when I need company, and thank you for being there. So when you approach it from a position of gratitude, I think they will understand and you will get what you need. And I just indulge yourself. You should have everything you want right now while you're going through this process.
Okay, I'd like to thank the panelists very much.
Thank you, guys.
So we're gonna head out to lunch. It's across the street by the cafeteria. So if you get treated here, you know where the cafeteria is. It's right outside. You can eat inside there. We have lunch. The first breakout session starts at 12:30. So you have them all printed on here. You go to your first breakout session by 12:30. That's when it starts. And between breakout sessions, you have 15 minutes to travel. There are volunteers, blue shirts all around that'll help you. And again, we have refreshments in the lobby at 2:15. And so again, head over to lunch. If you need assistance, a volunteer will help you. And we'll see you over there. Thank you.
There.